Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio on this beautiful Tuesday morning. 60-plus degrees. Time to get outside, enjoy a little sunlight, and start to shed those winter COVID blues. We are joined this morning by Dr. Lee Norman, who's back, who's going to help update us about the numbers across Kansas, how we can improve data reporting, and what's at stake in those numbers. But first, Doc Hawk, give us the good news.
Numbers are still good, holding steady at 70 total, but our active infections, I think at one point we're up to 38. Active infections, 33 currently, 11 in the ICU, 6 on the ventilator. We still do have 37 in that recovery period. Hays' numbers look to be holding steady too on that lower end, which is good. 15 total patients, 11 in that acute infection stage, and 4 in that recovery.
And you know, we just finished our chief medical officer call for the Kansas City metropolitan area. Numbers are down everywhere. It's not just a KU thing. This is an everywhere thing, which we really like. And one of the comments to make, we peaked at a high of about 25 new positives amongst our staff a day in November. And now we're down to about 1.
Yeah.
And we have 84% of our staff vaccinated. So what it tells us, vaccination works, infection control works, and I think there are a number of people in the community who have had COVID. So if we put all those numbers together, we may have more people have some current immunity than we otherwise would. What do you think, Hawk?
Yeah, you know, I agree. I think that data is kind of consistent with what we saw published in the Lancet with the Israeli studies. You know, they have a fairly small population and they can collect data relatively quickly, and that's what they've shown. And we've shown it in real world, in real time, on an everyday basis, and I think that's good.
We should ask Lee Norman what he thinks about that. Plus, just to say, for a couple of our hospitals, Liberty up in Liberty Hospital and then also St. Joe Hospital, both have a lot of strong nursing home connections, as does Advent, Shawnee Mission, St. Luke's. They're all talking about how few admissions they're getting from nursing homes now. Vaccine programs really had an effect, Lee Norman. What are your thoughts?
Yeah, agree wholeheartedly. 88% of our nursing home and long-term care people in Kansas have received the vaccine. There's about 10 or 12% that have chosen to not get the vaccine. About 65% of our staff have received, in long-term care and nursing facilities, have received the vaccine. The uptake by those staff, it seems to be a little lower than other healthcare settings. So we'll need to think through how to increase the use there. But the numbers, the vaccine program partly coming through the federal government with CVS and Walgreens, and partly with what we call the orphan facilities that are not regulated by CMS. We've had to find them and work with the counties to have those residents and staff be immunized. So it's been a very successful program. We've essentially wrapped up with the exception of some second doses in nursing home, long-term care residents and staff. So that's been a target population, along with healthcare. Steve, you pointed it out, 88% at your place. That's been a great response, and we're hoping to have a lot more of those that are choosing to delay it that will still sign up and get it in the future.
I think that, and it's clearly making a difference for our staffing. It's been great. We still have to make sure we take care of the new staff. Let's see if there are reporters on the line before we get into our discussion with Dr. Norman.
Yeah, hi. This is John Shorman at the Kansas City Star, and I have a question. For Dr. Norman related to testing, and this is obviously cases have been falling over the last few weeks, and that's obviously a great thing. At the same time, we've also seen a pretty substantial drop in the number of tests being administered, and I'm wondering if that fall in testing is any reason for concern, and what is the minimum or the floor that you need to maintain in terms of tests administered to have a good sense across the state of the spread of the disease?
Yeah, good question, John. Testing. We have had a drop-off in testing, and interestingly, in working with my colleagues, the state health officers from the other 54 states and territories, have seen it coast to coast, and the drop-off, that is. And I think it is fatigue. We've been trying to understand why. I think number one is fatigue. People just want to magically have this whole scourge go away. And I think also it's just less top of mind. People are, as Dr. Hawkinson pointed out, hospitals are kind of an indicator of the overall what's going on out in the communities. We've had, and I'll go over those numbers with you in a minute, Dr. Stites, but we've had a dramatic drop off in the number of cases, hospitalizations, and deaths. So I think it's less top of mind, John. The good news is that the percent positive is also dropping. It's down statewide to about 5%, and I'm thinking it's going to continue to drop off. It is still extremely valuable to us, though, obviously for testing symptomatic people who may have it. And then secondly, the surveillance as kids come back, teachers come back, businesses ramp up to their pre-COVID levels to do asymptomatic persons. I might mention again that one case of the B117 UK variant in Ellis County was found through routine testing of an athlete just as part of the athletics program. So it still has a very prominent place. We're not going to put the brake on this program. We've been naturally blessed, of course, to keeping it going by the federal CARES Act monies, and eventually they'll become a decision point is how much can we absorb that cost out of our own state coffers versus the federal dollars. I mean, I recognize it's all taxpayer money and we try to be good stewards, but we will be working with, and I'll be working with my colleagues to figure out at what point does it not make sense to have it quite so broadly available. I think the other thing, and Dr. Hawkinson may want to comment on this, is that we're going to have more widely available at home testing options. I think a big incremental step would be if we had a good home test, much like you have a home pregnancy test, to have a highly reliable, sensitive and specific home COVID test would be a way that would allow us to stand down some of these fairly expensive testing centers.
And Lee, I would just comment, in general, hospital census lags about 2 weeks behind where the community is. And the reality is when our hospital census has dropped from 100 plus in November, early December, down to 33 today for the acute infections, that just means there's less COVID in the community. Now, part of that's because we don't see it in nursing homes. Part of that is a lot of people have had it, and part of it is, 10 to 14% of the population is now vaccinated. But all of those are reasons that the numbers are going to decline. And I think that's the other thing. Yeah, I think the testing numbers have declined because, frankly, I know 2 weeks later, we're seeing less hospitalizations. Like, we're down by 70%. So that's a steep decline. There's just less COVID active in the community, I think, Lee. And I think part of it is less in vulnerable populations.
Yeah, that's exactly the point I was going to make. I think it is a good sign that our test positivity rate is down, not just the whole numbers. And we have to assume there is some sort of either asymptomatic spread out there. As we know, we have seen, is that 2 times the amount of the people that are being tested? Is it 4 times? At one point they were saying, 10 times the amount of disease out there than what actually has been testing. But to your point, we have, again, clinical real world experience showing that there is decreased spread because we don't see that in the hospitalizations. And we are seeing decreased hospitalizations, decreased deaths. And I think that really lends to there is probably less spread out there for different reasons, just as you mentioned. Hopefully there will be some readily available at-home testing for people to do on a regular basis. That has been one theory that has been touted for months now, almost a year, about being able to do that so that people can understand if you take a test once a day or every other day, and if that's positive, then you don't go to work, isolate, stay home, hopefully stop the spread. That's the main goal of all of this.
And 2 other quick comments. First, our average age has gone from 57 up to about 60, 61 currently, which is interesting without nursing home, without in nearly as many nursing home populations. So really, Lee, you and I are the vulnerable population right now, as we're the average, at least I'm the average, I can't speak for you, I guess, of the people coming in.
I'm above average.
Zinger, how about that one, brother?
Well, and it may point into the fact that you had talked about that a lot of people who are out doing some of those activities maybe tend to be younger, who are out still gathering in those large groups and parties, probably a little bit younger, so even those numbers of people are down.
Yeah.
And now we're kind of just really hitting some of that older population that really wasn't doing a lot of those behaviors, but seemed to still get it.
And it's still the vulnerable population. What's also interesting is our ICU numbers are way down, right? Our ICU's down to 10 this morning with 5 on ventilators. And we haven't been that low for quite a while. So that's also really good news because I think it means that people who are coming in aren't getting quite as sick right now. we'll take that too. Any other questions from reporters? All right, not hearing any.
No, I do have one. I was just
Go.
waiting
Yep,
for
yep.
John.
Yeah.
Okay. So Donna, first of all, with KMBC TV, wants you to know, Dr. Stites, that Cody is not the only one who listens.
All right, I'm going to take that. I'll remember that, John. Thank you. We're glad you're out there.
Her question is for the panel, and she wants to know, she knows a person who's in the proper tier, and the question is, do I travel to get the shot if I'm offered it? So apparently on the Missouri side, Columbia is calling people and saying, come on over and get a shot from Kansas City or St. Louis. And their question is, should you do that or should you wait for when it's closer to home?
Yeah.
I think I'd take the shot if it was offered to me, and you're available and you're able to travel, that you have the economic means to transport and
Yes.
things like that to go get it, and make sure you can do it twice, right? Because you got to get it. Once you go there, you got to go back for the second shot on the Missouri side, and so I think that's how I would approach it.
Yeah, that's what I would say too, is, understand the risk of where you have to go and getting there, weather, whatnot, be safe when traveling, do all those things. But I think if you're offered a shot and you have the means and you think you can do it, then certainly go get it. But understand, you really should go back to that second spot for your second dose.
Lee Norman, in Kansas, though, it's county by county, and the counties have sort of, at least here locally, they've clamped down a little bit and say you got to be, like when we're giving shots, helping with Johnson County residents, and we're said, listen, we're going to give you some vaccine, but you can only do Johnson County residents with that, and that's what we've been doing. I think Wyandotte County has not been using anybody else to do their shots. They're really doing it through their mass vaccination clinics, and I'm assuming you have to be a Wyandotte County resident. Are you seeing that across the state? What's going on out there?
Yeah, as a state, we have given the guidance that to receive the vaccine, you have to either be a resident of Kansas or work in Kansas. And we don't, as a state, say that counties, you can do whatever you want to and just contain it to your county residents. That they've chosen to do that on their own. And it has caused some problems, I'll tell you. For example, a critical worker, high contact worker in Sedgwood County was denied a vaccine. 59-year-old was denied by the employer because he didn't live in Sedgwood County. He went back to his other county, and I won't mention it, and they said, no, you're at 59, you're not in the right phase, and if it's your employer's problem. If you're a high contact critical worker, that's your employer's problem. So this guy was essentially cut loose from both counties. And I think that's a very myopic approach. My feeling is the county's line shouldn't make that much difference, but I do understand the logistics of allocation because it's based on a per capita basis, and I can understand counties wanting to serve their county residents first. But in the big scheme of things, I think it'll just impede the rollout to broader populations.
Yeah.
Okay, Bob and Mary want to know, why is Sedgwood County getting more vaccine than Johnson County that has a larger population? Is that even true?
Is that really true, Lee? Because you and I have talked before. You've said it's been handed out by county.
Yeah, neck and neck, those two. If you look 1 week to the next, there might be a little bit of variability, but those two have been getting equal amounts. I will say that it's not just purely on a per capita basis. There's the CDC, what's called the Social Vulnerability Index. There's about 17 counties in the state that, because of poverty or healthcare outcome inequities, et cetera, have a small modifier that can make a small bump to the counties that have a worse social vulnerability index. That's to try to direct more resources to them. But those two counties have been running neck and neck. They're the two largest counties, and they've been essentially getting the same. Now, the other thing is that it depends also, it's getting more complicated actually. Our per capita allocation is pretty easy. But now that the nursing homes are done and CVS and Walgreens isn't using our vaccine, it's always been our state vaccine, then that is spilling over into the general allocation. So that, for example, you've seen where we're starting to, not just starting, but are starting to finish off really teachers and teaching staff over the next couple of weeks. A lot of that is because of the long-term care vaccine is being then returned, if you will, to the state. You also see that there's a federal retail pharmacy program that is determined by CDC and the feds. And we don't even determine those. And those can go to some counties, and some counties don't get any of that. And yet that's not something that we even touch as a state. So we're trying to always load level. We have, for example, 30 counties in the state that are not getting any allocation this week. And the reason is because they're in phase 2. They've gotten 25 doses per 100 people. So we're shifting that to other counties where there's lagging behind. So to look at it as a duel between two counties, I think isn't really the right way to look at it, but rather how do we move the state through the second phase and then into subsequent phases.
And Lee, do you have some, you referenced some numbers earlier, and you may want to update us about the efforts to improve data reporting across Kansas and how important that is, especially regarding future allocation of vaccine.
Yeah, we've not had any penalty points against us, but therefore the holding back. We've gotten every single dose of vaccine that that we've been deserving of for the state of Kansas, 1% of the total. And but it is important. For example, and I can give you the numbers today, Steve. We've given in Kansas about a little over 514,000 doses have been given. That's out of about 645,000 doses that have been distributed to Kansas for a total of 80%. So 80% of the vaccine coming to us is recorded as having been administered. But we know there's a lot of doses out there that have put in people's arms that are not have not been recorded. So that's exactly what we're working on. Starting yesterday, as a matter of fact, we put in a kind of a painful workaround to make sure that we can find where all those doses are, because we do not want to be in the bottom third of the states. We want to move up. And I know that we have very little in inventory. I can tell you that yesterday, on my handy dandy Post-it note, we have 88,000 doses that are registered as being in inventory. And half of that is in 2 counties. Now, is that because of reporting? It's still on shelves, or is it in arms and just hasn't been put into the WebIZ, which is our state system that gets uploaded to the state? Long way of saying we want to reconcile for accountability purposes and for the public confidence that the vaccine is being used right, and when people get administered the dose, it gets put in. Now, last week we didn't get any, so it's going to be a mess this week. Now, let me rephrase that. It's going to be complicated this week because last week we didn't get administered any vaccine, so this week we're going to get a whole lot more, a couple 100,000 doses. So then it'll be a big bolus of vaccination done, and the data reporting will lag. And because they didn't fly, the airplanes weren't flying, and the people at Pfizer and Moderna weren't picking and packing the coolers and sending it out. So we just didn't get it because of the weather. We'll catch up.
I think they could have just hand delivered it last week. They probably could have walked it. It was so cold. Or maybe skied.
Yeah, well, I'm just glad I wasn't in Texas last week because, man, you know, they really got smacked.
They did. They did. So, Dr. Norman, so what's at stake about this? How will we put in the data? How could that impact our future vaccine allocation?
Well, the prior administration and this administration have not put in any plans to cut back on vaccine distribution. And the reason I brought up the 80%, the reason I brought that number up is both administrations have suggested that it would be if a state dropped below 70% of the doses being demonstrated as administered, then there would be a penalty and they'd have less distribution of vaccine. And that was originally stated as 70%. There's no program out there now to do this, but it looms. It doesn't do anybody any good to cut off vaccine to somebody, but we do have to demonstrate that we're good stewards of it, and that's why we have to fix this data thing. We're going to require on those those counties or those administrating entities, those sites, those vaccination sites, if they don't demonstrate to us through a very simple daily report, we're requiring a daily report, then they're going to send us what's called a flat file, think of it as a spreadsheet, with patient level information so that it gets in there. It's a lot of work for everybody. But the origin of this is the HL7 interface between two systems and whether they're talking. Steve, when we first started talking about the vaccine program, we talked about, remember 345 vaccinating sites? We now have 1,080 registered vaccinating sites. And you can imagine that some of these have not ever done vaccinations before. So therefore, it's kind of nightmarish to have those interfaces between whatever they're reporting into on the computer and the web-based system called WebIZ, which is our state-mandated, statute-driven reporting system from which the CDC pulls data into the COVID tracker. So it's just a ton of details to work through. We're trying to make it as easy for the vaccinating sites, but it's always, the counties that have done the best, it's real straightforward. They have 5 vaccinating sites, and they expect people to go to those 5 vaccinating sites. And when you only have 5 vaccinating sites doing the data reporting, it's pretty straightforward. When you have, in our case, we're probably now at about, I don't know, maybe 450 or 500 that are actively vaccinating, but that could well double if we get more vaccine in. It's really important to not outstrip our ability to capture the data. I know data is boring, but it's important.
It is important, isn't it? So Lee, one of the things I think we're struck with here in Kansas City, at least, is that patients have already had 1 dose on one side of the state line or the other, usually opposite, like some of our patients may have come over here and gotten 1 or vice versa. But now we're being told, gosh, you can't share doses across state lines, both Kansas and Missouri. Help us understand, how do we do that going forward when we have patients who have already had 1 dose on one side of the state line, and where are they going to go get that second dose?
I have assurances from Missouri that they can get their second dose at the same place where they got their first dose. And that is absolutely true on the Kansas side as well. And the reason is because that's the way the allocations work. If somebody tries or has, let's say, their first dose on the Missouri side, their second dose is not allocated to Kansas. Their second dose is allocated to Missouri. And it may not sound like a big deal.
Yeah, so let's say here, I'm sorry, here's how let's say we had a patient who's a Missouri resident or a staff member, doesn't matter. Somebody who came over, they got their first dose here in Kansas. Where will they get their second dose?
They'll get their second dose the same place they got their first dose.
They'll still be able to go leave Missouri, come over to Kansas, get a dose, then go back to Missouri. I mean, that's the question that's coming up, because we're hearing, gosh, we can't share doses anymore across state line. And so, under the table, the chief medical officers are all conspiring to share doses back and forth to make sure we get everybody vaccinated and we don't run into a problem around that.
I think as long as that gets reported in, the world's not going to fall apart. I think that it's a little bit, we say in Kansas, if you live and work in Kansas, you can get a vaccine 1 and 2 in Kansas if you live and work in Kansas. With patient care, that's a little bit different. And I think that it would take a cooperative venture across state lines to make sure that the people get their second dose, because it's all about the allocation of that second dose. I don't care, where they get as long as it's where it's allocated to, because then it syncs up right.
I think the numbers would wash out over time, so I think we'd probably all be okay, so. All right, let's see what questions. I bet there's some questions out there.
Yeah, we've got a lot of them, and they're a mashup. I'm going to start with Kelly. I'm just going to go down the line. She wants to know, she's got to take antibiotics for her tooth. Is it okay for her to get her COVID shot?
Yes.
Yes.
Okay. And Gary wants to know, Missouri is testing wastewater. This is a favorite question for Dr. Norman. He likes to talk about wastewater.
He hasn't talked about it yet, so this is awesome. I want to hear what he's got to say.
He loves dealing with wastewater.
And so anyway, Gary is asking, is Kansas doing wastewater testing, and what are you learning from it?
Oh, Lee Norman, I know you are doing some wastewater testing. What are you learning?
Sewage master.
Oh, and he also said that it showed on the Missouri side that the variant is showing up in the wastewater, so he wants to know if that's happening.
Yeah.
We've been doing wastewater testing for many, many months now. We were doing it before it was even very popular, and it's been remarkable, quite honestly. A good example would be Ellis County. It showed I talked a lot about that one variant in Ellis County, and then a little bit of an outbreak, which has subsequently become less of a problem. But the wastewater had an uptick before the clinical uptick in the number of cases occurred. So we're finding it to be helpful. It would surprise me if anybody's doing whole genomic sequencing on water. And the reason is because there's so much of it, and Dana maybe knows more about this than I do, but the whole genomic sequencing is tough when it's just viral fragments that are being assayed for in wastewater. But I can't comment on whether the variants are located in the water or not, because we don't do whole genomic sequencing of wastewater. But we can certainly tell you if there's an uptick, it's level, or it's dropping off. And by the way, mostly in most communities, large and small throughout the state, it's dropping off.
Lee Norman loves this topic so much. When he gets to talk about it, it's like he gets wasted.
All right. Lori wants to know, does the KDHE have any guidance on double masking?
Lee Norman, I look better with 2 masks on.
or more.
Or more, yeah.
We do not, it's not our guidance to double mask, but it is our guidance to wear a well-fitting mask. We're not big on face gaiters, and you see people that you could drive a semi-truck through that's so poorly fitting their mask. So we do provide guidance to have a well-fitting mask, and if it requires a second mask to have it hug your face tightly, then so be it.
And I think you'd agree.
Yeah.
It's a little harder for you bearded wonders to do that.
I'll have to trim, but but CDC guidance still is not to double mask. Again, just as Dr. Norman said, it's about the well-fitting mask, and they do talk about if you do wear double masks. The only thing that's been studied, and this came out because of that MMWR report where they looked at it, as well as just Dr. Fauci saying it makes common sense. But remember, what they studied was one surgical mask with one cotton mask over it, not two cotton masks and not two surgical masks. So that's the caveat for that. But again, to Dr. Fauci's words, it would make common sense if you do. Just remember, make sure it's comfortable for you, that you can breathe well and still get that gas exchange, because some people will feel it to be less comfortable than just wearing a single mask. But the important thing is the fit.
And so, and the loop, you can tie the knot in the loop to help you make sure it stays. What the loops can really do, you can also just flip the loop. They help keep it over your nose. I'm impressed by how many people start talking, that mask just drops right below their nose, and I just want to go over there and push it right back up.
Yeah.
So you guys comment, I saw a report today that the British variant may be looking a little bit more lethal. Have you guys seen that it's got a new modification in its spike protein? Have either of you heard that?
I've heard it, but we've only had 2 identified cases, and neither one of them were particularly, one wasn't ill at all, and the other one wasn't particularly ill. But I have read that in the news, but I don't have any specific information. Perhaps Dana does.
No, I haven't heard that, but I know even from the information that is out about the lethality and some of those, the group in the UK that writes on their opinion about it, going through all the data is not too consistent. So there are even some of the scientists who don't even fully believe that it is more lethal. So I think that question is still up for debate. We still need to see all the data on that, but we certainly continue to look at it on a daily basis.
Also comment about the recent thing that came out of the FDA yesterday saying that Moderna and Pfizer can move more, all vaccine makers, Moderna and Pfizer are the most nimble around this question, don't have to do the extensive testing with the vaccine when they do make a modification similar to the flu vaccine. They still have to look for immunogenicity, and they have to look, there was something else they had to do. But they still had to do something, but it wasn't the large-scale randomized trials. Comments, guys? Thoughts about that? Safety? Makes sense? Dr.
Makes
Norman?
sense. No, yep, agree.
Yeah, I mean, I think they must have been listening to our show because we kind of addressed
we've been
that.
pushing them for that.
As long as it was safe, and again, still this platform looks to be very safe, the mRNA platform. So I think that's a good thing. I think that can help expedite even further in this time of Operation Warp Speed to get those vaccines, pivot those vaccines to any of the new variant threats or any variant threats that may arise, and hopefully, we can also at some point put 2 or 3 different spikes in that platform if we can do it, if it's doable.
And it looked like it would take them about 4 months altogether from the, I've identified it, we can change, at least Moderna and Pfizer, change the vaccine, do the testing, and get it into the public. So that's pretty impressive.
Isaac wants to know, it's been 2 weeks since the Super Bowl. Is the panel concerned at all about seeing an uptick anytime soon from Super Bowl celebration?
I can't talk about the Super Bowl.
No.
I'm still in mourning.
Okay.
What was the Super Bowl?
What Super Bowl? You mean the one in 54? That was a great Super Bowl. Did we play in 55? I don't remember.
No, I think we are always concerned about upticks and surges, but I think that one event, that one day, all of our numbers, hospitalizations, deaths, and overall 7-day running averages have all gone down, so that's a good thing.
And Jill, not me, but I love her name, and Glenn have questions about people in different categories. Jill wants to know about when are teachers going to be vaccinated in Kansas? And Glenn wants to know, what about IT workers, Dr. Norman?
All right, Dr. Norman.
Are we essential?
And counties have been different. I think Wyandotte County went for teachers before Johnson County did, if I remember that right. I may have that inverted, so I apologize. I'm not trying to make anybody mad there, but I know it's a little different from county to county.
Well, it's based on the number of teachers and the amount of vaccine allocated. They've always been in phase 2. We're well into the way. We have 76,000 teachers and teacher staff. We probably have 20,000 that have been fully or vaccinated, at least with the first dose, we could very well, within the next 2 weeks, be finished with teachers. There's a bill floating through the legislature here in Kansas to have all schools back open toward the end of March, and I expect that we will have all the teachers and teaching staff, which includes bus drivers and crosswalk guards and the like, food service. Will be done, I think, within 2 or 3 weeks. So we're well down that road. We've got, I think, 20,000 doses allocated this week for teachers and teachers' staff. So we're not only have we begun, we're not far from being done, really.
And when will you? Where do college and grad school? Where do those faculty come into play, or are they just part of the general population?
Yeah, they're part of the general population for now, because of the fact that when you think about why do we have a prioritization list anyway, phase 1 through 5? What's the likelihood of professors or IT professionals, for example? What's the likelihood that they're going to catch the disease, have a bad illness and death? Very low. Proximity, can they control their proximity? Absolutely, they can put great distance between. Are they have students, but are they like preschool teachers that the kids have snotty noses and drooling on you and everything? No. College, a lot of colleges are remote anyway, and certainly they can distance well. Engineering controls, can we get some distance between us in the work setting? You can get all the distance in the world between you in a college setting or an IT setting for the most part. Most IT people are working at home anyway, in my experience. But so neither of those have evidence-based risk that put them in an upper category. It's not arbitrary, these decisions. It's based on what we know about these 5 criteria. They're all on our website, by the way, on kansasvaccine.gov under the handbook, the provider handbook. It explains them very carefully.
Yeah, I think overall, teachers and staff in Kansas, especially K through 12, should be fairly thankful. From what I understand, Missouri's having a little bit more difficult time about doing that. So I think it is very important and imperative to get, certified K through 12 workers vaccinated as soon as possible. I think all that helps to continue to have our kids in school, and we all want that for their benefit, for the parents' benefit. But we have to remember to continue to take those mitigation strategies and do those things to keep everybody safe.
What about hotel workers? They say they're not seeing that on the list. Do they need to look harder?
I think hotel workers will probably be in the population. I don't think it's going to be the worker classification on that one, Lee. Am I right? They'll just be classified with wherever they are.
Yeah, that's not a congregate work or living setting, so they've not been a prominent group that has become infected. So no.
I think, Lee, we always have to remind everybody, the problem here isn't prioritization on the list. The problem here is volume of vaccine. And what we really need is a whole lot of vaccination, and then for people to bring their arms and let's get going. And I think that that's still the biggest problem. You hear the angst and the questions because people want this vaccine, and for good reason. It works. But the problem is volume. Any prospects for increasing volume? I know Fauci was there for a while, said, April will be open up. Now it looks like May or June. What are your thoughts?
Yeah, I think that's probably right. When you think about it, we've had 10% of our population in Kansas, 1 out of 10 people have contracted the illness naturally. So we have another 12%, we'll say, give or take, that have been vaccinated with at least 1 vaccine. So you look toward the future, okay, we have 3 million Kansans, 1 out of 6 is a child that won't be eligible for the vaccine until which time anyway that one's approved. So just at 1 million people in phase 2, and we have 114,000 doses a week coming in at the current time. And now if J&J or AstraZeneca or one of those other ones came in, you can just do the math. And that's about, I think we're there, Steve, in terms of your estimation. Now, May would be optimistic, and hopefully we get more vaccine, because that will be the solution.
No, I think that's currently the solution. Yeah.
We have quite a few people that are upset about people that are 70 and older. They feel like they should have priority. Mm-hmm. Is there is it a similar discussion around them, Dr. Norman?
Yeah, instead of 65, we said it's 70. I've also heard 74, then I've heard 80. I mean, there's all sorts of things about there. Why isn't age a more powerful analytic for who should get the vaccine?
We've had enough vaccine for all those people to be vaccinated. I don't think it's a vaccine volume going into a county, for example, that's the problem. I think it's a fact that an individual or a couple living in their homes, they should have long ago been vaccinated, quite honestly. But they're not typically very good at accessing the internet, finding a website they can click on to register, and having an advocate that says, Mom or Dad, let me grab you. We can go down. There's the pharmacy has a vaccine, and we can get you vaccinated at the pharmacy. Because state guidance for phase 2 is 65 and above. And again, within counties, they have the ability to say, and it's all a matter of where you want to put the emphasis. If you want to do it on teachers or 65-year-olds or congregate living situations. So the counties do have a certain amount of sway. But if 70-year-olds, they should be vaccinated.
Yeah, I think, but it's a good point you raise, which is that many people are not electronically literate. So as we've looked through our patient list, we are making phone calls to patients. Back to that, we're sending mail to patients, trying to find ways to reach out to them besides the electronic methodology, because we know that some folks don't do that. And they may not have advocates. They may not have children who are helping them out. So they may not live in a nursing home. So if they're independent living, they really need to get the vaccine. So we've really tried the old-fashioned way with snail mail and phone calls as well.
And that works, Steve, and it has to be very customized, but it absolutely works. I will also give a tip of the hat. Hy-Vee hasn't gotten vaccine yet, but they are going to be one of the distributors. They've demonstrated through their outreach of influenza vaccine that they can reach those hard-to-reach populations, whether it's racial, ethnic, whether it's congregate housing, or just kind of shut-ins. And the governor met with them, I think, yesterday, and we're going to assist them in doing that kind of custom outreach. But this is when we have to look after our fellow citizens, let alone our mom and dad and grandparents, and say, let me work with you on this. I understand that you're not adept at navigating websites, and let me be your personal case manager or your navigator through this, because there is enough vaccine out there to do this. There was one vaccinating site in Kansas this last week in Johnson County that did 5,000 vaccines.
Sherry wants to know, if you go to home testing, how will they track that? How will you track those results?
We probably won't, quite honestly. We would like to. We're already facing that with antigen testing, because we do a lot of antigen testing in schools and prisons and those kind of places where we do surveillance. And even those are tough because it's a 15-minute point of care kind of bedside, if you will, test. And when we ask people to put it in, it's a mandate to record those, but we will lose track of overall numbers when it comes home to a home test, no question.
And Jeannie wants to know, do we have any numbers on the so-called long haulers? How prevalent is that, and is it being tracked?
That's not tracked through our state system, so we can't know that. I'm hoping that the research and CDC, although the CDC usually aggregates data from the state, I don't know the numbers. I know there are a lot, but
a lot. Do you know how many people are in our long haul clinic right now?
I don't. We
I
have
do.
a meeting soon. But
I actually have that number for the last 2 weeks. It's 29.
So not that many yet.
Yeah, they got the workflow going, and 2 weeks ago, and they started counting, and in 2 weeks' time, they signed up 29.
Yeah, so that's a good number, New, but I bet there's a lot more people out there. But some people are just going to be in there with their primary care physician with the long haul. So I think as the long haul symptoms become more prevalent, most primary care doctors will get pretty good at it.
And I would assume you can create an ICD-9 or ICD-10 code for that, so you can code it so that you can then track it and code, COVID, long COVID or long hauler, and then whatever specifics, and whether it's brain fog, anosmia, shortness of breath, dyspnea. I mean, that's going to be a pretty easy thing to do. Hopefully, moving forward, there will be some of that coding.
Yep.
Okay, and Lori, she has kind of a specific question that's targeted to us. She said if someone got a second dose because they tagged along and there was extra vaccine at the end, I think we had just a few situations of
Yeah,
that.
we've had a few cases like that where we were nearing the end. We had vaccine that hadn't been used, and so we reached out for whoever was around us to make sure it got in an arm without wasting it. Because once you commit to warming up Pfizer or Moderna, you got to use it.
Yeah, and they want to know, will they get their second dose here?
Yeah, we account for that when we do.
They
our-
won't
get
be
our
told to go
tests.
somewhere else.
No, you should have been everything recorded.
Yeah, you
scheduled.
generally get your appointment at the time. If you
Yeah.
haven't, you're going to get an appointment. So.
Okay, and then last question. We have a lot of people asking for you to forecast, and Dr. Norman, what will summer look like? Will campgrounds
love
be open?
forecasts.
Will we be going back to different things?
All right, Norman, we're going to Coffin Stadium this summer.
You remember it was a little over a year ago, we were talking about the Big 12 basketball tournament.
I do remember that.
Yeah.
I do remember that. We're trying to find ways of
KU
having
got
little
robbed.
pods there. I
Okay,
can't
you got robbed.
Yeah, KU got
I don't-
robbed. That's right.
I don't think our crystal ball was very functional that day because it was so early on in the pandemic. I think by the summertime, if we can get to, not to 12% vaccination rate, but to 50 to 60%, and like I said, 10 or probably 12% by then, we'll already have some degree of natural immunity. I think we'll start seeing more people gathering and that kind of thing. The question will be, at what point do we relax mask wearing, social distancing, and the like? I'm hoping that between that great sunshine, the natural protective effects of vitamin D in our bodies, and a mass take-up of vaccine, that we will, by summertime, have a much more normalcy.
Yeah, I'm going to bet on the fall, only because I think the vaccine, if we don't get it in large scale supply till June, and then I'm a little worried about natural immunity from people who've had COVID beginning to wane, and then folks starting to take their mask off. We're going to start seeing
Yeah.
we'll have another summer surge, and people get too comfortable. But so I'm going to bet where there will be another surge coming out as the weather warms up and we don't have enough folks vaccinated. But I'm going to say that by August, things are really going to be turning around for the better for the long term. So that we will be back at Coffin Stadium. It won't be full force, maybe full throttle in October when the Royals return to the playoffs this year, and certainly for Arrowhead as the Chiefs. We're going to kill it. Nah, that's not the right word. We are going to beat that. No, I can't quite say it like that either. We're going to take the stuffing out of the Tampa Bay Buccaneers. Let's go, Kansas City.
Yeah, right. Yeah, I think it could go one of two ways. Obviously, if there's these new variants that continue to spread, or if they start to dominate, or if there's other new variants we don't even know about yet, that could lead to further shutdowns, lockdowns, things of that nature. I'm hoping it doesn't go that way. I'm more optimistic, hoping that we can get back to doing more things because of maybe some mild immunity from having had the disease recently, but also vaccinations, mask wearing, get back out to do some of those things. Maybe by late spring, early summer. I don't know in what capacity, but again, I think you also have to understand probably the overwhelming force of people just being tired of doing what they're doing right now. Whether that's right or wrong, things may inch back towards normal, even if it's not the right time. We know we got, people want to get back together, and not only Arrowhead in the fall, but obviously Kenny Chesney is supposed to come. That's a huge concert to Arrowhead
You're really
in the
focused
spring.
on that Kenny Chesney
so
thing.
we're going to be, optimistic that we can do that and get out. But I think it's a lot of, I think it's more weariness, and it's the cows
It
that
is
we've talked
cows.
about. And people, again, whether it's right or wrong, people are going to inch towards back normalcy, come hell or high water. But that's not the safest thing to do. So I think there are just so many variables that we don't understand. If we can get Johnson & Johnson, Novavax, and AstraZeneca, if they can show safety and efficacy, that is going to be a huge step towards moving towards that.
I think so. Final thoughts, Lee Norman?
Well, Dana Hawkinson, you touched on something that I think is critically important. And that is, on one hand, there's the public policy implications of when do we kind of allow or loosen up to go back to normal. And then there's the social psychology of fatigue and resiliency kind of being stressed. So this requires wisdom, and that is to figure out where we should be. Someplace, lockdown, tight public policy will likely not be needed and would probably not be tolerated very well. But we don't want to fling the doors open like a party like it's 1999. So where can we meet? Where does social psychology meet public policy? And that's someplace in the middle. And maybe, I don't know, Steve, it's July, August, September, but I think what is it we can live with, and what is it we can be safe? without completely throwing the baby out with the bathwater.
You know, and I think as a final thought, hopefully, you know, as we have seen the protests or the demonstrations last summer, you know, hopefully working towards social justice. I think what we also saw from that is when, you know, groups of people are getting together, because really those demonstrators wore masks, most all of them. And I think that was another good clinical or social experience, showing we didn't have a lot of spread at that point. You know, you were outdoors, you were spread about as much as possible, and I think everybody was wearing masks, so I think that helps.
It demonstrates the truth. It demonstrates
the
same thing we prove every day here at KU in our COVID positive units. We don't spread the disease because we wear the masks. It makes a difference. Schools reopening, wore the masks.
Yeah.
KU had a great reopening, wore the masks. It does make a difference. Hey, tomorrow we have a session with Melissa Robinson, president of the Black Healthcare Coalition and Kansas City, Missouri councilwoman, who's going to join our update to talk about initiatives to overcome vaccine hesitation among our Black communities. She will talk about how the coalition has been working to overcome trust issues and the work that needs to be done. All right, folks, remember, faith, hope, science. We are on the comeback trail. Don't sacrifice the rules of infection control, which have kept you safe. Don't get cocky. Make sure you take this and get this across the finish line. We can do that because Kansas City, we're coming back. Come along. We're fast approaching our one-year anniversary for our first COVID-19 patient who arrived at the hospital last March. I know this has been a hard year for many of you, both mentally and physically. So we got a prescription for you today. Go outside and enjoy some sunshine and warmer temps. Wear a mask. Unless, of course, you're out by yourself. There's nobody around, then you don't have to have a mask on. Both that sunshine and those warmer temperatures are going to make us feel better. We know that seasonal affective disorder peaks in February. We know that is a really hard time. And we know that seasonal affective disorder coupled with COVID weariness syndrome equals sad cows. How do you beat sad cows? You get outside, you enjoy a little sun, you enjoy a little exercise, you enjoy a little bit of warmth. For more on overcoming seasonal affective disorder and depression during a pandemic, here is psychologist Dr. Steve Lassen with advice that's going to work for people of all ages. Remember, Kansas City, follow the rules of infection control. They've gotten you and they've kept you safe up until this moment and all the day long, and they'll keep you safe going into every day of the future. We're back with you tomorrow.
There's less sunlight, we're more sedentary because we're inside more, we're getting less physical activity, we're more isolated socially. We eat differently. Have you ever noticed how you eat differently in the winter? More comfort foods, carbohydrates, things like that. So all of those things can put us at risk for some mood changes. On top of that, with the pandemic, I think we have the whole country moving into this risky time of year already vulnerable because of the restrictions that have been in place. We've been more socially isolated, and we've been relying on things like getting outside, taking those walks, and getting fresh air and sunlight as a way to cope with all of this. One is making sure that we do get regular physical activity combined with being outside. Getting physical activity inside would be good, but being able to get outside for at least 5 to 15 minutes a day is going to give us the vitamin D that we need and help with mood overall. We know that the sunlight actually increases one of the neurotransmitters in our brain called serotonin, which is known to improve mood. Maintain a regular sleep cycle. And that's hard in the darker, colder months. You just don't want to get out of bed. And since we tend to eat worse in the winter months, making sure that you're maintaining a good, healthy diet. Supplementing with vitamin D, with omega-3 fatty acids can be good ways, low-risk ways of improving mood as well. We've had some time to practice this, so being able to make the most of what we have to work with, make the most of these virtual connections that we can make. Now would be a great time to try out a new hobby or to re-engage with a hobby that we've done in the past. Dust off the guitar or scrapbook or whatever it is, and do something that's enjoyable, that's going to keep you busy.